Hello everyone. Welcome to this very first talk. Welcome back to this monthly webinar. I used to do a lot of these for those that used to keep up with me probably about a year ago, maybe 2 years ago now. It's been a long time since I've last been online doing anything. I actually taken a bit of a break from social media as well on some level. I didn't even realize it'd be so long since I last did any sort of TikToks or anything like that. It's just been kind of busy, and I took a little bit of time off from work as well. So I have decided to come back and do this particular monthly webinar that I used to really enjoy doing, going through some hopefully interesting cases. Believe it or not, I actually learned more from you guys than I did from myself. I'm not going to claim to be some kind of expert in anything, really. I just like radiology. I like radiology a lot, and clearly I like to talk about radiology a lot as well. So today we are going to be doing the same formula as what we used to. We have a combination of plain films and x-rays, and we've also got some CT scans. We're going to work through it slowly and hopefully go through it together. There's going to be some discussion. I've had occasions where people said, no, you're wrong about that. And then I've been like, yeah, you're probably right. Oh, hi from Wales, Canada as well. Thank you so much for coming and turning up today. I have no idea what the time is in Canada. I don't know, is it early, late? It feels like it probably should be late. Someone's already put their hand up. Just feel free to put your messages into this chat over here. And so then that way I can kind of try and keep track of what's going on. I think because I'm working off one screen, I'm not entirely sure how to keep up with absolutely everything, but I'm going to do the best I can. Normally I have two screens with me, but today I've only got the one because I'm actually in a hotel somewhere in central London, which is very fancy. And it sounds very fancy, doesn't it? But anyway, I had some business to do up down here. So anyway, yeah, it's great to be back, and I hope everyone is well. We have created our own platform. Okay, let's just get to why we're here in the first place. So I am here on behalf of Radiology Seminars, which is essentially, I'm one of the co-founders of Radiology Seminars. It was born many years ago. It was through a conversation where I met someone Dr. Edsham Saeed, and we just hit it off, and we really enjoyed teaching. So we started off with a CT head course, and it went really, really well. And before I knew it, things just got escalated, and we loved it so much. We taught so much. We were getting really, really involved in it, and things just led one to another. And we're doing more courses and getting involved in more things. And now I do these webinar things and also get involved with Radiopedia and all that kind of stuff. So it's been a really, really fun ride. And Radiology Seminars is our company where we provide courses for anyone who wants to learn anything about radiology. We partnered up with some really interesting companies, actually. So Anubix does post-mortem CT. So that's a really big one that's coming up these days. And they do a really phenomenal course. Honestly, genuinely, we always offer these money back things. So if you're not happy, just take your money back. But genuinely, it's awesome. We've got fellowships. We've got an online community. And things are kind of hotting up now. Things are really, really carrying on and going quite well. So please do get involved. Please do check out the website. Lots of free stuff as well. I mean, I've been doing free for loads of years now, so there's lots of bank of material up there. And we also got the YouTube channel where lots of our previous webinars are there as well. So just get involved with the company on whatever level you want to. It's our company, it's my own company. It's very much on our own rules and stuff like that. But I'm always here to learn. I always want to learn from you guys. So you let us know if something's not going well, you're not happy about something, etc., etc. Right, so I am now going to share my screen. And this is going to go to one of our new endeavors, which is called Pax Bean, of all things. I know, it sounds very original. But Pax Bean is essentially, we were trying to figure out how to make teaching better. And we did use Collecting Minds for a while. We used various other DICOM viewers for a while. But then what we realized is that we didn't have as much control over what was going on in the background in terms of if we wanted to add something, it was always a long conversation. We always wanted to say, look, I reckon this could be better. And it just took ages. So we kind of took it on ourselves to develop this on our own. It's been quite a lot of work. But this has got some AI built in the background where once we've done these talks, the answers will be uploaded onto here and you'll be able to interact with the cases yourself and be able to type away and say, oh, I think it's this, I think it's that. And you'll be able to get your notes and all the rest of it as time goes on. So if you're interested in following the course, the talk with me, you can go to paxbean.com, get yourself a free account, log straight in and have a good look through the cases. As the months go on, we'll have August, September, and we'll just keep going. And then eventually we'll start splicing up the videos and putting all in here. So then if you wanted to go back, you can have a look back yourself as well. Right, so I am going to see, can I have chat function here? Yes, I can. So I've got the chat function kind of down here. And case number 1, yeah, good afternoon. Yeah, good afternoon. Good evening for me, I think, isn't it? Good evening. Anyway. Right, so we are going to do it. We're going to go through it. So here we go. This is a CT scan of someone who's very unwell. They came in during on call. They had a previous surgery and now they are deteriorating rapidly. And this is a CT scan. And from the outset, we can see that this is a CT of an abdomen and pelvis. So for those that don't know, I try and make this useful for all levels. So I'm going to go through it slowly and work through it as if I were on call. And these are where my mistakes can happen, because sometimes I don't even remember which case I put up there. And then it's only later I realize, oh, it was that case. Oops. Right. So we're having a look through this case. This is a CT abdomen and pelvis. And we notice the contrast enhanced scan because when you look at the aorta, let's see if I can get, yeah, here we go. Oops. Allow. You can see the aorta over here. That's got, it look kind of different color, it gives different density from the rest of things. So we've actually injected something into this person. And one of the simple ways to figure out where this arterial versus portovenous is just to have a look at the aorta and compare it to the portovenous system. And then the portovenous, you can see is slightly kind of more dense and slightly more bright. I mean, sometimes it can be kind of equal, but this one kind of looks slightly more bright. So we're going to say this is a portovenous phase image. Now, you may have noticed that there are a few very sort of white areas that can be hyperdense on CT, and hyperdense on CT can be a number of things, such as metal, but also it can be calcium, it can be bone. So when you look at bone, it looks like this, and it looks like there's some bone around the aorta. And actually that's called atherosclerosis. And you can see there's some atherosclerosis all the way along the aorta and some of the other smaller vessels as you go through the rest of the image body. But there is an area that has some calcifications that's not within the vascular system at all. And you can see here, this little area over here looks like this clumpy calcification that's located away from everything. And you first think, okay, could this be some sort of thrombus or something like that that's going on within some sort of vessel or something like that? But actually, when you follow it up, it looks like this sort of clumpy calcification goes all the way along and then goes along like this, goes all the way along like so. But it kind of gets a bit more bulky towards the tail end of it. And that's why I said tail, because actually this is the tail of the pancreas. What you've got here are these clumpy calcifications. We know the calcifications because they're hyperdense. And this is going to be clumpy calcification from previous bouts of inflammation. But what you notice is actually the pancreatic duct is quite dilated. Now, there's a number of causes for that, but it's just something to bank in our head. That's something that we've noticed from the outset. So the other thing we may have noticed from the lung base images, there are bilateral pleural effusions that are present here. You can see them right sitting over here. What it's done is kind of collapse the lung bases as well. So you've got some collapse or consolidation of the lung bases as a result of the bilateral pleural effusions. Now, that can result as a result of cardiogenic failure. It can happen for loads and loads of different reasons. But in someone who's clearly very unwell, this is just could be the way that they are. Now, this is the liver. For those that don't know, this thing that's sitting all over here. And you can see there's actually a bit of fluid just adjacent to the liver there. And as you scroll through, there's just generally a bit of fluid, but it doesn't seem to be kind of organized in any particular area to say that this is a collection. So a collection is fluid, but it's a collection is collected and has got a sort of hyper enhancing surrounding to make it a collection. That's something you need to go in and do something about. But when you've got free fluid, which is all floating around, like this person could turn to the left and turn to the right, and depending on where they've turned, that's where the fluid will go. So we've seen that there's a fair bit of intra-abdominal free fluid that's located here. So the liver itself doesn't look too bad. We've seen that the pancreas has got multiple calcifications, but these aren't things that are going to be really causing someone to be as well as this person apparently is. And so when you scroll through and have a look at the kidneys, scrolling through the kidneys, you've got one kidney here and you've got a renal cyst that's just located over here. So the renal cyst is nothing to worry about, just a bag of fluid, and you see that quite a lot. And if it was hyperdense or hyperenhancing, then we've got something to be concerned about. And when you look at this kidney over here, that doesn't look too bad. Everything looks okay. And the gallbladder is sitting over here as well and doesn't look particularly inflamed. It doesn't look like it's got any radiopaque calculus or calculi. And we say radiopaque, and when I do my reporting, I always say radiopaque because sometimes you get less opaque or not so dense calculi, and that's going to be a bit difficult to see on a CT scan. Sometimes you don't see anything. Sometimes you see some little black dots sitting in there because they're very they've got lots of cholesterol within them. So now we've had a look at the kidneys, we've had a look at the liver, we've seen the pancreas looks a bit odd. We need to have a look and follow the bowel. And I always do this with every single case. So the bowel is over here and we follow this along and we just follow this along. And this can be really hard in the beginning, but I promise you, the more you do, the better you get at this and you can kind of really whiz through eventually. I feel like I've lost it, but no, here it is sitting over here. And one of the constants I always said or used to say and will say now is that you've got your descending and ascending colon that almost kind of stapled down and everything else kind of moves around. The sigmoid colon, transverse colon, the small bowel moves around. But if you get lost, is go back to the ascending and the descending colon, and that should usually lead you the way. So this is the descending colon, and counterintuitively, we're going upwards. We're going across to the transverse colon, across to this side, across to this side, across to this side. And then we are going to have to follow this to the hepatic flexure. Hepatic because the liver's there. And we come all the way down to the very end over here. And actually, this bowel looks okay. But this person is really, really unwell, really, really sick. They've got sepsis, they've got temperatures, they're becoming hypovolemic. We're worried about this person. So we need to think about other things that could be causing this person's problems. So we've seen the bilateral pleural effusions, we've seen some ascites, no bowel problems, and the rest of it actually looks okay. But when we start moving outside the body, we may notice that there is a bit of subcutaneous fluid all over the place. Got lots of edema, but not just that. There does appear to be some more kind of confluent fluid located within this region here, and actually there's some intermingled low density stuff. So if I click onto this area here, which is the lung windows, anything that's very, very black is going to be air. And here you can see that this looks like quite an extensive amount of air that's not only located within this region over here, it's extending up the thigh, down the thigh, up the left abdomen, up the central abdomen, and all the way up the left side of the body. And it's actually going up both sides as well. So this person has got an extensive amount of subcutaneous air and subcutaneous edema. So with someone this unwell, we have to start thinking about something like gangrene. Now, gangrene is something where you get infection. It starts to produce some kind of gas, and then it starts to really degrade and start to cause necrosis of the surrounding tissues. And you can get gangrene in all sorts of areas, but this seems like a very kind of, I wouldn't say special, it's a horrible kind of gangrene called Fournier's gangrene. Now, Fournier's gangrene can come from the scrotum. So we have to look at the scrotum and think to ourselves, is this where this is coming from? Yes, you will get certificates. It will be CPD points at the end of this. So you can see here, this is clearly the testicular region, and you can see within this there's multiple locules of air, and there's also what looks like a hyper-enhancing contour all the way around it, both sides. So it feels like, okay, what must be happening here is that you've got infection, really bad infection, the scrotal sac. This could happen for multiple reasons, diabetes, anything. And that can cause this kind of infection. There's really quite significant Fournier's gangrene. But this is not an ordinary case, and I try my best when I can to get some cases that are a little bit more interesting, not so interesting for the patient, but interesting for us to learn from and hopefully be better from doing so. So when you see this, you can kind of say, okay, it's coming from there, let's move on, I'm not interested in anything else. But actually, when you look at this and follow it around the back, you see that actually it goes all the way around. Can you show where's the jejunum? Jejunum. Okay, fine, I'll find the jejunum for you. But can you see here, this is a collection that seems to be around the rectum or the perianal region. So this looks like a perianal collection that's advancing forwards, going into the scrotum, and then you've got such significant emphysema and gas-forming organisms. It's causing problems and causing this necrosis. So someone's asked about the jejunum and where. I'm going to expand that so I can just see what you said. Is this seminar about plain films? There will be some plain films in this seminar. You said, please show with the jejunum, where's the ileum? Okay, fine, let's do that. So I will go back here, back here, and then full screen. So jejunum, so I would normally follow from the stomach. So stomach is here. You can follow the stomach this way. You've got your duodenum. It goes along this way. And then you're going to start to get the subproximal small bowel. And this area can generally be really difficult to follow. I mean, I'm following it just because someone's asked to. But this is going to be where your sort of jejunum is. Ileum is going to be sort of your terminal ileum. So you go to the cecal pole. So remember I said about constants? So you've got your hepatic flexure, your ascending colon, you follow that all the way down, and then you will have, so this is not such a great example, but normally you have like a fatty sort of lip structure that's going to be the ileocecal valve. So that fatty lip is going to look like this, but it's going to be within the bowel. I can't see that, but you can see the sort of bowel coming out this way and following along. And as long as it's not blind ending, which I don't think it is, it might be actually, no, I don't think it is. Yeah, follows along this way. That's going to be your terminal ileum. That's how you find that. So I would go for constants. Constants can be stomach, unless someone's removed it. And your next constant will be the cecal pole, or basically the ascending colon, and that will usually let you follow all the way along. So this is quite an interesting case of someone with Fournier's gangrene. Oh, I forgot to put the question thing back up. So I don't know why some of the questions are not coming up all the way through, but this seminar will have some plain films as well. So what I'm going to do is like 5 CTs and five plain films as well, just to make things interesting. Right, so I can't actually remember what this one is, but I think, oh yes. So this is a person who came in with abdominal pain, and this has been going on for 3 days now. And we've decided to do a CT scan and figure out what's going on. Now, what I did a really sort of slow kind of work through on the first one. I'm not that I'm going to go any faster, but I'm going to do something that I always teach people to do, my registrars and anyone who's interested in imaging, is to do a scroll through, do one scroll through. Don't think about anything else, just have a look. Because what your brain gets good at is identifying what's the abnormality, which just really jump at you at some points. What's this, another question coming up? I can't really expand it. Can I expand it? Okay, I'm gonna, okay, someone's asked a question. Let's see what they're saying. Could you try to take us through history for case 1? Yeah, this person, it ended up being a perianal abscess, which resulted in Fournier's gangrene. So the infection essentially moved forwards anterior, which is very unusual, into the scrotal sac area, and then ended up giving them Fournier's gangrene. Right, so for this next case, let's minimize this bit over here, put that there, and then get you guys over here maybe, and get the chat function going. I don't know why, but the chat function is not showing that last question. So I'll try my best to try and keep up with it. Okay, so I actually find probably better to scroll from here. So we're going to scroll all the way down. I'll do one scroll through, and the more you do the one scroll through, the more likely abnormalities is going to pop at you. Just going to sort of turn up like, oh, I didn't see that coming. So we scroll all the way down like so, scroll all the way down like so, scroll all the way down like so, all the way down, all the way down, all the way down, and all the way down to the very end. Okay, so we scrolled all the way down to the bottom, and then we'll see if anyone has seen anything abnormal. But if you haven't, don't worry, we're going to work through this. So first off, it's a CT scan. What kind of phases it? Have we got contrast? I think so, because we can see that aorta looks slightly more bright than it should do. Is it portovenous phase? I feel like that's slightly brighter, almost the same. So say portovenous phase image, definitely not arterial. And this is a CT scan going all the way through. Okay, so the lung base looks like it's got a pleural effusion. That's definitely true. We don't have any lung windows, but we can definitely say that there is some consolidation located at the lung base over here. The left lung base doesn't look so bad, but this pleural effusion feels like, well, does it go that way? Does it kind of extend all the way along? It does seem a bit odd, doesn't it? So let's find this pleural effusion and just see where it starts and where it finishes. So see a line going along that way, and it goes all that way, and then it just stops. And then this new kind of area pops up over here. So this is what we think, okay, so maybe it's not pleural effusion, because it's very unusual for pleural effusion to go all the way from like the lung all the way to around the liver like that, unless there's some sort of perforation or something, right? So we're not saying that's not the case, but it did seem like there was no real communication between the two areas. But having said that, there are a few locules of air located within this area of fluid. So there must be some kind of communication of air from somewhere. Could it be the lung, or could it be something else? So looking at this liver, it looks like this liver is kind of being really pushed along, right? It's been really pushed inward. So it's causing some level of scalloping. So this fluid collection is outside the liver, pushing everything inwards and away from itself. And then it looks like it kind of finishes there. And I know it's a collection because do you remember when we looked at the ascites on the previous case? This case actually has a kind of hyper-enhancing rim around the fluid that is around the liver. So this is clearly organized on itself on some level. Okay, gallbladder. Could it be connected to the gallbladder? It could be. Sometimes you get a gallbladder perforation and that can result in a collection. But that gallbladder looks like doesn't look particularly inflamed. If you look at the fat there and look at the fat around the gallbladder fat looks pretty well preserved. And I don't think I can see a definitive defect located within that area at all. Now we have built some level of zoom. So let's see if I can zoom in and then scroll again and just try and have another look at that gallbladder. And yet again, I don't think I can really say I can see any sort of perforation anywhere along there. Okay, so then we have to think to ourselves, okay, we've got a collection. There's definitely some air with it. I'm not convinced it's kind of communicating with the lungs. It has to be communicating with something else that can give air towards it. And the only other thing that can give air towards it is going to be bowel. It's going to be bowel, right? So first, let's make sure we've got the pancreas. Pancreas looks like normal over there. We have adrenal glands. So there's one adrenal gland there. Adrenal glands are not usually going to cause pain unless they're bleeding of some sort. But anyway, that's the kidney there. That kidney looks okay. The fatty hind of the kidney here looks okay as well. And then you get some bit of breathing artifact, but the spleen looks okay. And again, you do have some atherosclerosis of some of the aorta. Right, so this is the rectum. Just follow all the way this way, all the way up. And then you can see that going into there. A bit difficult to see, but you can see the bowel going this way, sigmoid colon. Then we're following this by mouse. We're on the descending colon, splenic flexure, going all the way across like so. And we can see we're up to the hepatic flexure, and I can't see connection between the hepatic flexure and this collection that we saw at all. And now we're coming down to the cecal pole. Now, if you're curious about where the ileum would be, a bit difficult again to see, but I think you can see a bit of a fatty lips over here and a bit of this bowel poking out somewhere. It's hard to really see where that ileum is going to be coming from, but I suspect it's going to be somewhere along around these regions over here. That's going to be your terminal. Oh, there we go. Terminal ileum goes this way, all the way. So I was actually wrong about the fatty ileum being there. I think your terminal ileum is connected just over here. So then we think, okay, we have to go from the top. So it's a good thing someone asked about the jejunum earlier. So let's go for the stomach. We're going along, where the first part of the duodenum, we're going down, we've gone to the second, third, fourth, going all the way along like this. And actually that early part of the jejunum looks okay. Now let's say I was in a situation where I haven't identified the problem. All I know is got a collection and some air within the upper abdomen. So I would say, I mean, I don't know the statistics, but most likely, most of the time, you're going to have to go with something like significant amount of air, collection in the upper abdomen, no specific cause can be found. Given the area of collection and air, the most likely cause would be a perforated duodenal ulcer. I mean, that's something you'd have to say because that's most likely can be the cause. But on this particular case, you can actually see, if you come down this way, you can see a little bit of this air. You can see that poking that way, little kind of beak just there. If you follow that, it's going towards your duodenum, coming out with like a little beak, following this way, and then coming this way. So this person was actually someone who used to drink a lot, and so they clearly have a bit of a irregular looking liver. They must have perforated and didn't go to hospital very quickly at all. And so ended up lying on their side and probably drank some more, hoping that the pain would go away, and it didn't really go away. And that's why a lot of the air that you normally get would be dissipated absolutely everywhere is now more focally collected towards this side of the abdomen and around the liver. So it's quite an interesting case of acute, but not as acute as you'd normally get it, because normally it'd be much more acute than that. Right, let's see if there's any questions that came up for that. No questions from what I can see, so it must be doing a decent job. Let's go on to the next case. So it looks like a two-parter we put in, and looks like we've got a CT head scan to look at. So let's put that there. Where do I have to get my question thing? Right, so let's go through. So we've got bone windows and brain windows. Okay, so let's look at the brain windows first. So we've got brain windows here, and it looks like this person's clearly quite unwell. Let's just do one scroll through. We haven't gone through the brain properly together yet. And we just have a look and see what's happening. So we can see that there is what looks like a bit of this soft tissue stuff sitting around the outside of the cranium on this side. So this is going to be a subcutaneous hematoma. And then you can see there's an asymmetry. So in our course, the acute CT course, which you can get online, I think it's on demand at the moment. We may bring it back live at some point. And it's actually the first course that built Radiology Seminars. So you look for symmetry. Like you've got to look for symmetry, right? We love symmetry. And so you've got to look and see, is this asymmetrical or not? And actually the CSF spaces are completely effaced here and not so effaced here. So you can see the CSF spaces are not so obvious, but over here they are. So there's asymmetry. So we're really concerned about something going on this side. You've got this hyperdense stuff. So this hyperdense stuff is hemorrhage, kind of acute acute hemorrhage. So we're just saying that there's acute hemorrhage at this point in time, all the way along this side. We can see it kind of tracking along this way, maybe along this way, maybe some hemorrhage located within the sphenoid sinus here. And have we seen any more hemorrhage anywhere else? Yeah, I think there might be. So when you scroll down this area, I feel like there's a bit of hyperdensity there, and linear hyperdensities maybe in the posterior aspect over here. So that can happen in acute traumatic injuries where you can get a few different kinds of bleed. So we've got a few different kinds of bleed. Ultimately, we've got an acute intracranial hemorrhage. Looks like it's be post-traumatic. You've got this hematoma, subcutaneous hematoma lying over here. When it's linear and thin like this, we say it looks like a spider's leg. And so if it looks like a spider's leg, it's going to be an arachnoid hemorrhage. So a subarachnoid hemorrhage. If it's going to look like crescentic, where it kind of follows along and kind of goes across suture lines, so these are going to be where the suture lines are, then you're looking at a subdural hematoma, and it's quite a thin subdural hematoma going all the way along like so. And I felt as though there was some linear kind of abnormality just located within these areas over here, so smaller acute subdural hematomas as well. Now it looks like they've got a line here, can you see that, going all the way down, a hyperdense line, so someone's done something about it. They put a line in to try and relieve some of the pressure that they would be getting. So extensive bleeds, extensive edema can start pushing things around in the brain, and the brain doesn't like to be pushed around. And so when it gets pushed around, it starts to have problems. It goes in what we call midline shift. So midline shift could happen this way, can happen this way, depending on where the pathology is. And actually, if you draw a line like this, you feel as though things are slightly pushed. And we would say there is some midline shift towards the left as a result of the combination of bleeds that we've seen on this cranium at the moment. So we've got these bleeds and we think, okay, great, all done, right? We can stop now. But actually, we do have to look a little bit further. Let's have a look at the bones. And now, I know they're not the best bone images available, but you can actually notice that, can you see here, that cranium looks like it's slightly out of sync. It looks like there's a fracture that goes all the way along like this and maybe extends towards one of the sutures along there. So it looks like they've got an acute fracture located there, and it looks like they've got a fracture going all the way down the occipital bone over here. So we could stop there and say, okay, look, we've done what we need to do. We've got someone who's clearly got quite significant fractures. They've got extensive bleeds, midline shift, and someone's done something about it. We're good. Let's just move on now. We don't need to do anything else. But the reason why I thought this case is really interesting is because when you scroll all the way down to the very, very bottom here, you may notice that there's something up. And what I'm going to do is I'm going to just extend. I want you guys to look at this and just see what you think. Sorry, my earphone's messing up. See what you think. What am I getting at here? What's the abnormality that I'm finding a little bit odd around this area over here? Let's see if anyone's going to take the bait. No one yet. That's fine. We will go back and then get the chat function back open. So what's happening here is that I would be concerned that we've got airway adjunct, that's for sure, going all the way down. But that thing there that's kind of coiled up within the mouth, that doesn't look right. You don't normally get something coiled up like that. And the only thing I can think of is going to be something like an NG tube. And then you're worried that the NG tube might be coiled up and not correctly in the right place. So then what we did is have a look at the X-ray. So I don't know how well this projects. I'm doing my best to window it, and I have no idea. I mean, there's going to be a few glitches here and there, so I will fix it. But you can see that I'm going to window it as best as possible. So that one was a car crash. They had loss of consciousness, had the CT scan, was not regaining consciousness. They had the repeat CT scan, and this is what the CT scan was for. And so you can see here that the NG tube tip is very, very dense. And that's why we make it dense so that we can see where it is. But it doesn't go down the midline, doesn't bisect the carina, doesn't go down below the left hemidiaphragm. It does not look like it's the fundus of the stomach. In fact, if I was to zoom in, this NG tube is located in the upper neck and needs to be put back in place. And it all came from the CT. Otherwise, I would never have been seen. I would have just said, okay, multiple bleeds, and that's it, we're done. But actually, there's a bit more to that story than that. Okay, so people want stories. Good. I will try my best to try and remember the stories for these patients as we go through. So let's do a run through for this one. So this is a CT scan. Oh, this is a young man for case one. So someone, could you take us through the patient history for case one? Did I not do that already? Okay, it was someone who came in with fevers and was getting worse, and it turned out they had a history of perianal abscesses, and that's what we saw in the CT scan. Okay, so for this one, this is a young man who came in and they had blood in their stools and really bad abdominal pain. So let's have a look through this CT scan. And again, we can see this is a contrast-enhanced study, scrolling all the way through. And we try and figure out, okay, what kind of, is it arterial, is it portal venous phase? And actually this time, aorta looks kind of almost identical to the portal vein, but we're going to say it's a portal venous or a bit of a mixture. But the artery doesn't look particularly dense. And after a while, you can tell like a young patient, this looks like a fairly young patient. They were only like 22, 23, something like that. So let's have a look. They've got abdominal pain. So gallbladder looks okay, not much the way of fat stranding. The kidneys are here and here. And you can see nice fat in the hilar region. So that's normal, that's good. Pancreas is sitting somewhere over here. So can you see that fluffy thing just sitting there? That's your pancreas. Not much the way of fat stranding. So we can't say there's any inflammation located within those regions. So now we have to think about what's going on. Let's go to the bowel. So we go from the rectum, going all the way up, all the way up, all the way up like so. And then we just follow this, keep following with me, keep following with me. We're here. This is the descending colon, following up, following up, following up, following up. I think we got to the hepatic flexure. It connects here, going across. Hepatic flexure goes all the way along like this. Oh, it's tough. Where's it gone? What happened to it? Is it somewhere here? Okay, so I've kind of lost it. But what I'll do, I'll go from my constant. So one of my constants is going to be the ascending colon. So the ascending colon goes to the hepatic flexure. Oh, connects there. That connects there. That connects there. And then, oh, I see. So then that's how the transverse goes. It's kind of curled in on itself a little bit there. So we can see as we scroll down, we come down to the ascending colon, and it's here it starts to look a bit odd, doesn't it? So look, that's what bowel looks like for this person. I mean, everyone's bowel can look a bit different. As you come down here, it looks a bit off. It looks like it's got a bit thickened. Come further down, it looks really thick, like really, really thick. Coming down to here, it looks very strandy on the inside. And then you can't really see, oh yeah, then we're coming up this way, okay. And then it all looks a bit odd, doesn't it? So we have to think to ourselves, like, what could be going on here, right? We've got someone who is a young patient. They come with abdominal pain and blood in their stools. And we've got this really thickened piece of bowel located in the region of the ascending and the cecal pole region. So what's odd about this is that you've got this sort of fat density on the outside, which is your intra-abdominal fat, but it also looks like there's fat density on the inside of this bowel as well. So how is that connected? How does that go from one to the other? And actually, you can look, it looks like these vessels are not too different from the vessels you get within the bowel mesentery. So let's follow that up and see where it goes. And actually, it opens out towards the bowel. You see that? So you follow that, it opens in, goes in that way, goes in that way, and goes all the way along. So what's actually happened here is that this is called an intersusception. So this is where you get telescoping of the bowel. So you've got a bit of bowel like this and a bit of bowel like this, and it kind of swallows itself in like this. And then you get the sort of bowel mesentery, you get the bowel fat all kind of engulfing in itself and becoming this telescope kind of appearance. So I think, great, you know, we've sorted out this person's got this telescoping of bowel, they've got an intersusception. But again, there has to be a reason for intersusception, right? I mean, you can't just have interception. I mean, you can, but someone who's a bit older than that shouldn't usually have interception. There must be something going on. So what could be causing it? Usually it's going to be some kind of malignancy, some kind of lesion, some kind of lymph node or something that's there. You've got to look for it. So if we come back to this area, we can see that's a kind of very misty looking mesentery that's kind of in there. We know it's that because it kind of continues from here. So you've got bowel mesentery and vessels. You follow that along, and then the bowel kind of fat, or this fat kind of disappears, doesn't it? Completely gone. And you get another piece of fat that looks very different from the rest. Doesn't look inflamed, looks almost identical, and no one's touched it. It's like nothing's happened to it. But every other bit of fat within this area looks very, very inflamed. So this looks separate. Let's see if it connects, and it doesn't. It doesn't connect. So this is a lipoma. It's a small lipoma that's connected over here, which is located within this region. And this is what's been the lead point of the deception for this person. And from what I remember, they went to surgery and they just couldn't, they kept trying to undo it and it just wasn't happening. So they just cut the bits of bowel and stick them together. Really, really unfortunate thing to happen for this person, but it happened. And a really interesting case that they gave us as well. Right, so I'm conscious of time. Okay, so what was that question? I have no idea. Could I? I don't know why, but I can't get the questions to maximize. Let me see if I can try again. Okay, let's just do this. Yeah, they were young. I mean, they must have had a lipoma for forever. I have no idea. It was very, very weird. They were a young person. You can see from the scan, if you can see they're a young person from their scan. Look at the bones, look at everything. They're a very, very young person. I mean, they're not like a teenager because they don't have growth plates, but they were young. Yeah. Right. Anyway, so let's have just make sure there was no more questions that were there. Yeah. Okay. Fine. Let's go on to the next case. So, give me a second. So let's have a look at this next case. So case 4. Oh no, so we're case 5 now. So case 5, and let's have a look at this one. And what we'll do, keep the questions open. Unfortunately, I can't see that. You can see that. I don't know if you can see it on my screen, but that last question's not turning up. So I'll do the best I can. Hopefully I'm doing all right today. Right, let's have a look at this. So this is again a CT scan, adult patient. We look like it's a portovenous phase. And there's some shiny stuff sitting over here. So this shiny stuff looks a bit bright. It looks like shimmering, right? So if it's shimmering like that, it's probably going to be metal, like metallic clips. Most likely a previous cholecystectomy on this person. You've got your pancreas sitting here, and you've got your liver sitting here. Okay, so we're trying to find out. So this person was a youngish patient. Don't quote me. There must have been like 30s or something. Really bad abdominal pain, fever, and it was originally centrally, but yeah, it was very central abdominal pain. They thought it could be diverticulitis or could it be appendicitis. So let's have a look through. And we have got the gallbladder, which is missing. We've got we've got the kidneys actually look okay. You can see they look okay because the fatty hilam's still there. Can't see any sort of evidence of any obstruction. And you've got your pancreas that is sitting over here as well, and that looks okay as well. And the spleen sitting here, adrenals are sitting over here. So now we have to think to ourselves, okay, maybe it's the bowel that's causing the problem, all right? So we come down to the pelvis, and there is a bit of free fluid there, isn't there? A little bit of free fluid there, but actually you can get a bit of free fluid in female patients. So it's not something to be particularly concerned about, but we do have a potential clue as to something that's going on with this person. So let's scroll through. So we follow this along. Rectosigmoid junction we've done, sigmoid colon, that was quick. We're going to the descending colon. We're coming up to the hepatic flexure, coming up to the transverse colon, going all the way across, hepatic flexure. So I said splenic flexure, hepatic flexure, coming down to the ascending colon. Okay, sort of veers towards the center, doesn't it? Okay, are we in small bowel now? What's going on? So all towards the center, it's very central, whatever this is. And it does get a bit odd here, doesn't it? So what's going on? So so the whole thing kind of gears towards the center, but it looks very inflamed around there, very thickened. And actually there's this thing here, is that terminal ileum. Comes out this way, goes this way. Oh, and it stops. So if that's stopping, let's see where the terminal ileum is. Oh, terminal ileum's there. So I was looking for a fatty lips on some of the other cases where I couldn't see before, but this has fatty lips, just there. So that must be the ileocecal valve, and that must be the terminal ileum. And I can actually follow that all the way around for the terminal ileum. A bit difficult, but it must be veering off towards somewhere this way. So this is a blind ending loop. And if you've got blind ending loop in the region of the cecal pole, it's going to be an appendix. So this is going to be acute appendicitis on this person. It hasn't perforated. There's no collection at the time of the study. These are important negatives to write when you're doing the report. Okay, so we are going to go to case number 6. We have come to some x-rays. Right, so x-rays wise, okay, first off, what are we looking at? We are looking at a young person. This is a young person because we can see that this has got some growth plates. This person's come in with knee pain. So this person's coming with knee pain. We look for anything grossly abnormal. And please feel free to put in what you think is going on. But what I normally do, if I'm not entirely sure, is, and I always encourage all registrars and everyone to do this, is really draw a line, like a pencil line, all the way around, and then always draw like a really bad line around the growth plate. So what you'll see is that kind of veers off this way and then comes back again. So it veers off this way, because sometimes people try and draw like a really solid line. I was noticed, oh, a bit of cortex going out that way. It must be some kind of injury. But that's not the case here. You have to kind of draw a really bad line, go around a bit if you have to. Really bad line, go draw around a bit if you have to. And the growth plate itself looks very, very well defined. So we're not worried about the growth plate. If we follow the edge over here like this, that goes all the way along like so, all the way along like so. Can't see any osteochondral defects here at all. Tubular plates look okay, and the femoral, the fibular head looks okay as well. We've got the patella sitting there, so that looks all right, doesn't it? So we've got a scroll button, then we've got a few more. All right, so yeah, look, I think we've got the follow-up. So actually, when we zoom in here, that growth plate doesn't look quite right. You can see that growth plate's nice and crisp, nice and crisp, nice and crisp. And then here, it just looks a bit irregular, you know, when you look at it. And actually, when you look at the texture of the bone there, it doesn't look quite right. It looks a bit mottled. And so this is where we've got to start thinking about, we've got to start thinking to ourselves about, okay, have I done this wrong? Yeah, so we've got to start thinking about something aggressive. We think about aggressive versus non-aggressive lesions, right? So an aggressive lesion is going to be something where you can't really draw a line around it. Well, this one, I don't think you can really draw a line around it. And you can see that there is slight sort of irregularity of the cortex over here. Not convinced there's going to be much in the way of cortical reaction, soft tissue reaction, not really. Okay, so then looks like we had a follow-up scan for the same person. And this, or maybe it's the other leg. So let's have a look. Is it the same leg? Oops. Zoom out a bit. I think it's the same leg. Look, and then it's got worse. Like something else happening over. It's slightly different because before we had it over here, but now we've got it over here. And now we've got a sagittal view and it looks very, very abnormal there. Look, that's normal bone. You've got normal trabecular pattern, and here it doesn't look right. You've got to be concerned that this can be something quite serious, right? Because when you get a young person with these sort of very abnormal, sclerotic, ill-defined areas, then you've got to start thinking to yourself, like, okay, are we worried about some sort of Ewing sarcoma, some sort of sarcoma that's located there? But it turned out the person also had pain in their shoulder. And then when you did the MRI of that one, you can see that actually there is this increased lamellation, this is sort of linear cortical reaction, irregular cortex over here, irregular contours, irregular appearance to the trabecular pattern. It looks very, very unusual, looks very, very odd. You can see they're a young patient because they've got growth plates. Another view of the same thing. So when you get this sort of, I mean, with these kind of things, when I report them and I only got one, then I'll be concerned it could be an underlying sarcoma, and I'll end up reporting it to the sarcoma center. Even if you've got like 2-3 areas, I'd still be concerned because they could have underlying metastatic disease. But in this particular case, it turned out to be CRMO, which is sort of a inflammatory condition that can happen to young patients who are growing up, and they kind of come and go, and they can have multiple areas, and that's going to be one of the big clues behind it. But for our purposes, if we see sort of aggressive features, and actually all you can really say is aggressive versus non-aggressive. People try and say malignant versus non-malignant. You can't really say that. You've got to go for aggressive versus non-aggressive. And then when you say aggressive, describe what the aggressive features are. You say mottled appearance, cortical reaction, soft tissue swelling, ill-defined contours, all that kind of stuff will automatically tell someone that there's something to be taken a little bit more seriously. I did see someone, lymphoma. Yeah, it could be lymphoma, like anything, you know, nephroblastoma, anything that can cause metastatic disease. Unless you're talking about the other one with the lipoma. That was clearly a lipoma because it was such a fat density lesion. But with this one, yeah, I mean, it could be, destructive bone disease as a result of that kind of thing. Right, so let's open the chat function again and have a look at this X-ray. Okay, so this X-ray is of an ankle, and they've come in, and at first, I don't think I can see anything that bad. Okay, so base of fifth is always a good place to look. See if there's a fracture there. I can't see a fracture at the base of the fifth. Osteochondral defects can be really sneaky. In fact, I did get caught out with one. I thought that it was an osteochondral defect because of the overlying tibial plateau, but it just wasn't. It was actually an osteochondral defect, which was just slightly separate. It was annoying, but it was there. But This is not an osteochondritis. You can see that's overlap there, and the medial malleolus and the lateral malleolus actually look okay. But what I'd say is that when you feel your ankles, generally speaking, the skin should really overlie the malleoli quite nicely. But this one, you can see there's a whole load of soft tissue, a whole load of soft tissue. There's something not quite right. Either they've had some kind of ligaments injury, or they've had some kind of there might be something, ligaments injury, a tendon injury, something that's caused a significant inflammation. Maybe it's just bruising. But when you come up to the lateral images, now you can see how bad this actually is. So you can see this line going all the way along like so, all the way along like so. And that's going to be sort of a lateral malleolar fracture. And there is the impression of a potential fracture of the posterior aspect of the posterior malleolus there as well. So just illustrating the really important point of getting looking at all views, like really look at all views, because sometimes it can be a bit deceiving. Now, one area that I've noticed over the years is this area here. Now, this can get fractured just out here, and that can be really hard to see on an X-ray. So sometimes you get someone who has a seemingly normal X-ray, and you end up having to get an MRI scan or a CT scan, and there's little tiny fractures just at that tip of the calcaneus, just as it articulates to the cuboid. It happens so often. So just something to be aware of, like if you do have someone who's coming with pain post-trauma and it's not getting better, then you may need to think about doing more imaging for that person. Okay, so we have got a chest X-ray, shortness of breath, sudden onset, and let's try and window this first. Let's try and get some good windowing here. That's a bit better, isn't it? Right, so I always do basics. I always look at the costophrenic angles, make sure they're nice and sharp. I look at the hilar. So these are the hilar regions, look like they're okay. And I check behind the heart and under the hemidiaphragms. And I also check the lung apices. Now, lung apices are really notorious for missing small pneumothoraces. But this one, there's a difference between there and there. Can you see that? And so one of my consultants used to say, always draw a square like this and a square like this with your hand if you have to, and just try and draw that square and kind of compare the two. And I've caught a lot of pneumothoraces like that. I don't think you really need to draw a square here. You can see that this is clearly an abnormal area located over here. This is some radiopacity located within the right upper lobe. Now, actually, now we've looked at this, you think to yourself, okay, is this added value or value taken away? And what I mean by that is when you put things into the body, things get pushed around. Remember with the brain, like you push something in, then things start getting pushed across. So have we got any midline shift here? It's going to be difficult to be 100% sure, but we do have the end of the clavicle here, and that is going to be, I think they're slightly rotated, so not be 100% sure, but it doesn't feel like things have really been pushed in any particular direction per se. When you look at the hilum, this one and this one, this looks slightly elevated compared to that one. So you could say there's some slight hilar elevation. You look at the hemidiaphragm, sometimes you get a bit of a tenting of the hemidiaphragm, and this particular case, we do not. But generally speaking, it looks like there may be some loss of volume. Also, another way to check is have a look at the space between the ribs. This looks slightly wider than there. So you could say there's a bit of loss of volume here. So what's caused it is going to be a right upper lobe collapse. And this is actually a really good example. I think it's called a golden S sign. People love this sign. I never report these signs. I don't think there's much point. But I always describe it. And I say radiopacity, loss of hilum, elevated hilum, crowded ribs on the right hemithorax. This will be consistent with the right upper lobe collapse. Lots of reasons cause that. Endobronchial lesions, mucus plugging, lymph nodes, hilar mass, mediastinal masses, they can cause all those kind of thing. And this, I would say that you need to get a CT scan as soon as possible for someone like this, just on the off chance it's something more sinister. Okay, let's have a look at this one. This one, I think they fell off a ladder and they twisted their foot, and now we're complaining about a lot of foot pain. And they left it for days, as you do. And so now what we'll do, we'll have a look, and first off have a look at the terminal phalanges. And I always find that the terminal phalanx is where a lot of fractures get missed, and because you're looking at everywhere else, and this is what we say in radiology. Most often, it's going to be the most often missed fracture is the second fracture. And so you might get really kind of focused around this area, but not look at the terminal phalanx. I actually try and do the opposite. I always go for the things that people wouldn't go for first, and then I go for the things that people would go for. So the terminal phalanx looks okay. These phalanges look okay. Then what you want to do is have a look at the shafts of the metatarsals just to make sure there's no evidence of any periosteal reaction anywhere. There's no periosteal reaction, so that we can't say there's a stress fracture. Now, you can sometimes catch a fibula, lateral malleolar fracture. Sometimes you get a navicular bone fracture. Navicular actually looks okay. But as you look at the contours, if you draw around the base over here and draw around the base of the second metatarsal, this starts to feel a bit odd. It looks like slightly out of line with that intercuneiform space. On top of that, there's this very sort of sharp contour stuff over here, and that looks very separate from the cuneiform. The fact that sharp, like normal bone is rounded, it's been with you your whole life. Fractures are new, they've been introduced. And so this looks very, very sharp and is also located within this region. So if I saw this, I'd be very concerned that there's going to be an underlying fracture located there and potentially a Lisfranc ligament injury. And when you get Lisfranc ligament injuries, the entire tarsometatarsal joints can kind of just slip along the side. And that's not good news for the patient in the long term. So very, very important that you do see this and notice that as well. Okay, another chest x-ray. And I think, if I remember correctly, this is actually related to a previous patient that we saw. It was the one who was ETOH++, drank a lot and ended up having abdominal pain. And we saw that they probably had a perforation. And so if we just follow the rules, or if we look at the costophrenic angles here and here, they look okay. Hyla, they look pretty good. Let me just do the window thing so that we just get that a little bit better. That's better, isn't it? Look at the lung apices, and yeah, I can't see any masses like we saw with that golden S sign, and we can't see any evidence of any lung contours that suggest there's a pneumothorax. And when you look at the ribs, they don't look particularly crowded. And so lung apices okay, hyla look okay. Let's look behind the heart. Behind the heart looks okay. Now it's the diaphragms, under the diaphragms. So this is where your stomach bubble is. That's kind of what we expect. But there shouldn't be an interface between the liver and the diaphragm. They're both soft tissue structures. They're right next to each other. There should not be an interface there. But here you can see there's an interface here. And that interface can only be introduced by something that's lower density than everything else around it. And that's going to be air. In this particular case, we've got air. And on top of that, it's a bit like that case that we saw earlier. That one had a fluid level because it had a collection. And again, you can actually see a fluid level. It doesn't conform to bowel. This is a fluid level. It doesn't kind of go in like a longitudinal direction. It's all sitting at the top here. So this is going to be a perforation. And I don't think personally I would call a collection or anything like that on an X-ray. I think that'd be pretty legendary if you could do that. I would just say perforation, recommend a CT to identify the cause for something like this. We are coming up to time soon and we are on the last two cases. So for those that have stuck with me, I genuinely appreciate it so much, unlike you wouldn't believe. I haven't done this in ages and I hope I've done a decent job being back at this. Okay, so this is a chest x-ray and it looks a bit odd, doesn't it? And so these are the ones where I would actually look at previous x-rays for the same patient just to make sure that this is the way they've always looked. That is a clue because there's something very odd about this one, right? So when you look at the costophrenic angles, these look okay and the lung apices look okay and the hyla look okay. But when you look behind the heart, where is the heart? It's not there. Actually, the heart is pointing the other way. So when you've got the heart pointing the other way, and someone's got breathlessness and fevers like this person's got, by the way, you've got to start thinking along the lines of situs inversus. And when you've got situs inversus, you can get something called cartilaginous disease. Cartilaginous disease is where you get can you re-explain how you know that? Which one? Okay, I'm going to just... can you re-explain how you know the structure is? Okay, I'll go back to that at the end. Please stick around. I will go back especially for you, okay, for the appendix case, yeah? Fine. So for this one, we can see that the heart has gone wrong way, and so we are concerned this person may have situs inversus. So we did a CT scan for this person. Oh, please tell me I uploaded the lung windows. I did. Good. Okay, the system works. And we scroll down, and we can see the heart is pointing the wrong direction. Very odd. And actually, when you look at these airways, they look like little dots, but actually they're continuous airways going all the way along. And actually, when you come along this way, they look like a pacified airways. What I mean by that is mucus plugging. So mucus plugging is what happens when you've got no cilia. Cilia kind of help you kind of push the gunk out of your lungs. People who've got cartilaginous disease they've got, I can't remember what it's called now, but they've got no cilia that to push that stuff out, and so end up getting these repeated infections and can get bronchiectasis, and that can continue to happen and becomes a vicious cycle. But that's what we're seeing here, the situs inversus. Actually, you can see the liver's on the wrong side and the spleen's on the wrong side as well. So that's quite an interesting case. Someone has asked me to go back to the appendix case. So let's go back to the appendix. Oh, you have to try and remember which one it was. Let's see. I wonder if I can remember. Was it this one? No. One afterwards. Yep. Okay, so someone has asked me, how do I know this appendix? How can I identify the appendix? Oops, am I still sharing? Yes, I am. So look. The way I know that this is the appendix, the only way to really know is that A, it comes off the cecum, and B, it's blind ending. A blind ending piece of bowel is going to be the appendix. And we also identified the cecum, and we also identified the terminal ileum. So if we did this again, so I'm going to skip the first bit, go straight for the hepatic flexure. We follow that down, follow that down, and you can see, normally you'd have the cecum around here, but it doesn't seem to finish. It veers off towards this way, and then goes down to this way, and then it feels like the cecal pole is here. And you get this thing kind of poking out the back over here. And where does that go? It kind of continues, doesn't it? It seems to continue into more bowel, and you could try and follow that around if you really wanted to. But that over there is also this sort of fatty area, and that's going to be ileocecal valve. So I know that this is going to be the cecum. It has to be the cecum. So when I come further down and come to this piece of bowel comes off here, curves around a little finger, but it is literally a little finger. It just stops. It doesn't go anywhere else. So that is the definition for appendix. Like, it just has to be the appendix. And this is what it looks. And when you look at the fat around it, it looks a bit strandy. Look at the fat there, it looks normal. That's strandy. Therefore, this is going to be an inflamed appendix, and it fits with the overall thing. So hopefully I've answered that question. I think we've come up to the end of this. This is my first day back. I really appreciate it. Thank you so much for so many people turning up. I think we've had a massive amount of interest in this. I do intend on continuing. Do email us with whatever you wish. You should be able to access the cases yourself, go through it later. At some point, we'll be uploading the teaching I put on here onto there, so you'll be able to go through it, and there is an element of AI that will help you go through the case as well. So I am going to leave it there. I hope I did all right. I mean, any feedback is good feedback. I said that wrong. Any bad feedback is good feedback, because ultimately you do want to make this as good as possible. For those that remember, I used to do this monthly for Collective Minds, and it was great fun. I got to know a lot of people and learn a lot of things from so many of you. So please do get involved, share it with your friends. It'll probably end up on the YouTube channel at some point. And if you are interested in going to any good courses, and there are plenty of good courses out there, but we run some good ones at Radiology Seminars, so do check them out. And with that, I think we're going to call it a day. So everyone have a great evening, afternoon, morning, wherever you are. It's been an absolute pleasure. Bye.